So that's my institution in Canada. We cater the northwest of Ontario, which is almost 5 times bigger than Pakistan, but the population is only 500,000. In Canada, we have the best care. So whenever the injury happens, the paramedics, they arrive on the scene and they have to document everything, that how the patient GCS is, neurological status is, and how they have transported. And on delivery, then they have to document the neurological status again to the doctor. So it is all documented. So when the patient is handed over to you, then it is under your care, you are responsible for the best managed care in the world. So the odontoid fractures, as we know, they're common in skiing resorts and particularly fall injuries, and sometimes also the motor vehicle accidents. Type 1, type 2, type 3, as you know, most common is type 2, which we treat. So the question is, what is the best management for these fractures, type 1, type 2, type 3? So every patient is different, and you have to judge yourself that what is the best course of treatment for every patient. Though there are guidelines, which we have read in the books, that it can be treated in hard collar or in halo, or we can do the surgery for these patients. And it is your responsibility to decide what is the best management for type 2 fractures, which is the commonest fracture. So I will just take you through that 30% rate of non-union in external immobilization for these fractures. So if you have treated this fracture with hard collar or halo, this doesn't mean that the fracture will heal. Still, there's a 30% chance that there will be a failure of treatment. So the patients, if they are over 50 years of age, there is high risk that it will not heal in external immobilization device. And particularly if the displacement is more than 5 millimeter, the rate of failure is higher. And disruption of transverse ligament, which is very important to see on the MRI scan. If that's disrupted or injured, this means it will not heal in external device. The accumulated fracture is also a high risk. So we treat these fractures either anteriorly or posteriorly, as you know. So anterior approach, we preserve the motion of the neck. Otherwise, you will lose 50% rotation of the neck if you treat posteriorly. So this is a patient. On arrival, you can see this is the CT scan on arrival, and then this is in the hard collar. So my question to the audience is, how many of you will treat this fracture anteriorly? Can you raise your hands? And how many of you will treat this posteriorly? Okay, so posterior cervical instrumentation, these are the options, but most common is the C2, C1 transarticular screws. So if we do the wiring or clamps for these fractures, we know that this accepted method of holding the graft to C1, C2 posterior arches. Wires can be sublaminar or through the C2 spinous process. But there is always a risk to the spinal cord while we are wiring it. And post-op, you have to put this patient in halo. Sometimes these wires, they can interfere with your MRI scan later on. So though we can do it, but they are not in fashion nowadays. These are different techniques. You have might seen these pictures in the books. Galli's fusion, segmental wire, Songer fusion. When I was under training, these Songer's fusion and the Galli's fusion, we have to explain to our mentors what's the difference. But I don't know it is in fashion anymore. So then we have these pedicle screws, pass screws to fuse these fractures. And again, this is a dislocated fracture. We can use these techniques for this fracture. And particularly the transarticular screw is quite easy to put if in experienced hands, but there are some risk as well, the risk to the spinal cord, the risks to the vertebral artery, and then you have to strengthen this posteriorly as well if the bone quality is very poor, particularly these patients, they are old, fragile, and osteoporotic. So in that cases, you might have to strengthen the articular screw with some additional wiring or spinous screw insertion. The patient has been delivered to you or have seen by you 3 months, 4 months after the fracture, or there is a non-union in external device, if there's a pseudoarthrosis and still there is instability at that level. So these are the cases where you have to insert C2, C1 screw. And in rheumatoid arthritis cases, this is also a very good technique. But you can't do it if there is a damage to the vertebral artery on one side and there is only one vertebral artery is viable. In those cases, it is contraindicated. If you cannot reduce C1, C2, this means you cannot have the trajectory for this screw. And if during surgery there is an injury to one vertebral artery, then you can't proceed to the contralateral side. It is a 3-column fixation. It is quite a rigid immobilization, and it is direct arthrodesis. Can you extend this to the occipital as well later on if needed? Yes. Yes. You can take the graft from the allograft. You can use the spinous process for the grafting as well. So I actually treated this patient anteriorly. I took him, I opened, and manually I reduced the fracture, and also I put the well tongs, and I put 50 pounds of weight, and I paralyzed the patient completely. So it nicely reduced, and then I just treated this anteriorly. So odontoid screw placement is only in experienced hands 1 and 1.5 hour procedure. But I tell my patients, particularly if they are old and fragile, that the most common complication which can happen is dysphagia and pneumonia. And I tell my patients who are 85 and plus that the surgery is not going to kill you, but there is a high risk that pneumonia will kill you. So they have to be aware that this can happen, that post-op complication of dysphagia, pneumonia, and old age is quite common. And usually these fractures, if they're not traumatic, due to fall in drunken state, they happen in old and fragile elderly patients. So as you know that it's a quite easy procedure in experienced hands. Indications are very clear. In osteoporosis, yes, there will be problem, but if you keep the collar on for a longer period of time, sometimes I ask them that usually it is 3 months, but it can be extended to 6 months. It heals well, but if there is any pseudoarthrosis around the fracture, then I discuss with them the posterior approach. There is the contraindication, the barrel chest, short neck, and thoracic kyphosis. For this, I went to Memphis with Medtronic. I invented this my own system, and I use it. So all those contraindication patients, I can put them this screw without any issues. So this is another patient of mine. He is 6 years old. He has a odontoid fracture and C5-6 subluxation together, which was fixed by this technique. So I will stop here. Any questions? Thank you very much.